name is Dr. Tosi Guilford. I'm a family medicine physician and I work in the School of Health Professions in the Physician Assistant Studies program. Today we're going to do an examination on the abdomen, and Erin Dorman, who is a physician assistant student, is going to help us out with that examination today. So before we start our examination, we want to always make sure that the patient is comfortable. This is really important with the abdominal exam because a lot of times our patients present with abdominal pain and discomfort, and so we want to kind of limit the changes in positions as we proceed through the examination. So for me, I like to make sure that the footrest is out first. That will help to kind of decrease the tension on the abdomen, and it be able to relax, and you will have an easier time palpating the abdomen. And then we also would like the patient to lay flat as much as possible. Now, of course, if the patient is in any respiratory distress or is uncomfortable and they can't lay flat, then you can always keep the bed elevated at about 15 degrees or so. But for the purposes of our exam, I'll make sure that I can put the table all the way down. All right, and I'll have Erin lay down. And if the patient is in significant pain and they're guarding, voluntary or involuntarily, you can always put a pillow underneath the patient's legs to kind of ease that tension on their abdomen. And if they feel a little bit uncomfortable, you can also put a pillow underneath their neck. So there are several different ways that you can drape the patient. She has on a gown, and some providers actually ask the patient to put their gown on where it is open towards the back, and that allows you to kind of raise the gown maybe to the level of the xiphoid process, and then you can use the drape that is in the room to cover the lower extremity and the pelvic area. I like the patient to actually put their gown on where it is open to the front, especially if it is a female with pendulous breasts. And when you put the patient in this position, and if they have on a regular bra or if they take their bra off, you can actually, that allows the breast to kind of naturally spread apart, kind of move over to both lateral sides, and you can tuck this underneath and cover the inferior portions of the breast. So this is kind of how I like the patient to be dressed. Okay, so Erin, I'm going to kind of keep this open. You really want from the level of the xiphoid process all the way down to the pelvic area, so you can kind of expose the entire abdomen. So of course, the very first thing that we always do is we inspect. Now with the abdomen, you're not only inspecting the abdomen, but I always begin with inspecting initially when I come inside the room, inspecting how the patient is laying down, if they're kind of in a fetal position, if they're rocking back and forth, if they're in a lot of pain. I'm looking at their facial expressions, and when I'm palpating as well, I'm continuously looking at their facial expressions to make sure they're still comfortable as I proceed with the exam. So of course, we have already interviewed the patient, and she would have told me that she has pain in a certain area. And just keep in mind, anytime you have a patient with abdominal pain, you always save that area for last. So I will inspect that area, but as far as percussion and palpation, I will always save that area for last. All right? So I'm looking at Erin, and she's comfortable. She seems comfortable. She's smiling, so that's always good. But I'm also looking at the abdomen. I'm looking at the contour of the abdomen to see if it's an obese abdomen, if it's a protuberant abdomen, if it's a scaphoid abdomen, very thin. Patients have very flat abdomens. I'm also not only looking at the 4 quadrants of the abdomen, but also in the flank areas, because if a patient has ascites or increased fluid buildup within the peritoneum, then that fluid, as the patient lays down, will disperse towards the flank. So we're looking at all of this. So shape, symmetry, make sure one side is symmetrical in relation to the other side. We're looking for any abnormal pulsations or propulsions, and we're also looking for any abnormal scars. So if they had surgical scars, and then lastly, I will also look for any protrusions, so any hernias or anything like that that I need to assess when we palpate. Okay, so she has a nice flat abdomen. There's no abnormal pulsations or propulsions. And of course, if you see some abnormal pulsations that you want to assess a little bit more, you can always use a pen light and use tangential light to see how rhythmic those pulsations are. Okay, so after we inspect the abdomen, we will proceed to auscultation of the abdomen. And we want to auscultate all 4 quadrants of the abdomen, and we're just listening for any abnormal bowel sounds. Hopefully we will appreciate normal bowel sounds, but if you hear any abnormalities upon auscultation, then you can note those in your documentation. And so when you auscultate the abdomen for bowel sounds, of course, we just use the diaphragm. And if you notice my hands, I kind of cupped my the diaphragm of my stethoscope while I was interviewing Aaron, just to ensure that the diaphragm is warm and not cold upon placing it on the abdomen for auscultation. Okay, so I'll auscultate in all 4 quadrants. All right, and she has normal symmetric bowel sounds in all 4 quadrants. Typically, as soon as you place the stethoscope on the abdomen, you will automatically hear bowel sounds. Sometimes it may take up to a minute to appreciate bowel sounds. Just remember, before you say that bowel sounds are completely absent or not appreciated, you need to make sure that you listen or auscultate each quadrant up to 5 minutes before you absolutely say that you can't appreciate any bowel sounds. All right, so after we auscultate for bowel sounds, we will move on to auscultation of the vasculature, so the underlying vasculature in the abdomen, which is the aorta, bilateral renal arteries, bilateral iliac arteries, and lower in the abdomen are the bilateral femoral arteries. All right. And those arteries we will auscultate with the diaphragm first, and then we will auscultate with the bale. And we're listening for bruits, which kind of helps us to appreciate any associated stenosis of the underlying arteries. All right? So with the diaphragm, we'll listen to the aorta, area of the bilateral renal arteries, area of the bilateral iliac arteries. And then I always tell the patient before I proceed with the femoral artery, I'm just going to auscultate a little bit lower in your pelvic area and bilateral femoral artery. Okay, and then we will turn to the bale and auscultate in those same areas. So we have completed our auscultation of the abdomen, and so we will proceed to percussion of the abdomen. And we're basically percussing the same area, so in all the 4 quadrants, and I typically percuss maybe 2 areas in each 4 quadrant. After we do that, then I will proceed to percussion of the liver span, and then I will show you how to percuss on the left side of the upper abdomen for the splenic, for any splenomegaly, so the normal size of the spleen. All right? So we are listening when we percuss. The normal percussion note typically predominantly will be tympani. If you have an area that is overlying maybe stool, or if the patient is constipated, if there's an underlying mass or a solid tumor, then of course that will be replaced with dullness. All right, so we'll go ahead and percuss all 4 quadrants. And that's dull because we're in the area of the colon. Okay? And now we'll kind of lift this up, and we will percuss the liver span. Typically, I like to start from superior and percuss my way down, and then start inferiorly and percuss my way up. Superiorly, we are percussing in the area of the mid-clavicular line. We're starting around T4, so the area of the nipple, and we will percuss down, listening for an area of resonance to dullness, all right, which is the superior border of the liver. And then I would usually start around the area of the umbilicus in the mid-clavicular line, and palpate up, and you're listening for transition from tympani to dullness. Once you hear that transition, then you will mark those lines and you will measure it, okay? The normal measurement of the liver span in the mid-clavicular line is 6 to 12 centimeters, all right? So I have Erin lift her sports bra up a little bit, all right? And then just a little bit up right there. And let me check one more time. And I always double check, and it was the same area, okay? And you're gonna relax. And like I said, I always check twice. All right, and remember this should be 6 to 12 centimeters. Okay, so now we're going to proceed to kind of assessing for splenomegaly. As you can see that I have positioned myself on the left side of the patient's bed to give me more access to her anterior axillary line. So typically a patient that does not have splenomegaly, so normal spleen, and even minimal splenomegaly, the spleen will still be located very high up within the rib cage, all right? So it's tucked behind these costal margins, and you should typically not be able to percuss out the spleen. If a patient does have splenomegaly, that spleen, instead of being kind of tucked behind the costal margin, that spleen will start to kind of migrate inferiorly and more laterally. And so just keep in mind that when you are percussing out the spleen. Okay, and so when I percuss out the spleen, I typically kind of start at the area of the inferior costal margin, and I start kind of mid-clavicular line, and then I percuss all the way down as I progress to the anterior axillary line, and I'm listening for a shift in dullness, okay? All right, so here's her inferior portion of her axillary line. And you can hear it hasn't really changed. That the percussion note that I'm getting, you know, has not changed at all. So it's just still tympanic. And remember, when we palpated this left lower quadrant, we had a little bit of dullness, and it's probably because we were over the area of her colon, basically. Okay. And that's how you kind of just assess for splenomegaly. So we're finished with our percussion, and we will move on to palpation of the abdomen. So the very first thing that we want to do is palpate lightly. And remember, if a patient has pain anywhere, we always ask them to use one finger, point to the area of pain, and we want to make sure that we stay away from that quadrant until the very end, and we'll go back and assess that area. Keep in mind also, when you are palpating, you're not only palpating and feeling the abdomen for any abnormal changes underlying that in that area, but we're also frequently looking up at the patient's face and making sure that they're not grimacing, that they're still comfortable. And we always put all these clues together to see, you know, if the patient if it lines up, if their chief complaint kind of lines up to what we're seeing in our examination. All right, so when we palpate, we're going to palpate lightly first. I'm right hand dominant, so I always just use my right hand. Make sure my hands are warm. All right, and then we just want to palpate very lightly. And always, like I said, just kind of two areas. All right, and then we want to palpate with two hands kind of deeply in those areas. And the bladder is kind of in that area too, so with the abdomen, you're always kind of assessing that area as well, okay? And then we move on to palpating the underlying organs, so your liver in the right upper quadrant, and then your spleen in the left upper quadrant. And you always kind of use the same hand to stabilize underneath the patient, whether you're, assessing the right side of the abdomen or the left side of the abdomen. So my left hand is always my stabilizing hand. I'm going to put my hand underneath your back, and what you're doing is trying to bring those organs forward. And when you use your palpating hand to press down, you should be able to appreciate the underlying organs a little bit more, okay? All right, take a deep breath in and then relax. And then let it go. All right. And not every patient you'll be able to feel, kind of like Aaron. And the spleen, you typically will not be able to feel that, all right? You can also hook the liver, and I can feel just a little bit of her tip of her liver, inferior portion of her liver. When you do your abdominal examinations, and you can see I've cut all my nails off, but you want to make sure that you have very short nails so you're not clawing into the patient's skin, but you can also hook the liver. Let me just mention this. When you are assessing the patient in their liver, what you're trying to feel for is kind of the tip of the liver. If you do feel the tip of the inferior portion of the liver, it should be very smooth, not nodular. It shouldn't be tender or painful. And sometimes when you have the patient take a deep breath in, you can feel that tip kind of hit your finger and kind of move down. And then as they exhale, then, you may be able to feel it kind of escape your finger and kind of retract back up into the costal margin. And so the same thing with hooking the liver. You are kind of burying your fingers underneath the costal angle, and you are trying to assess to see if you can feel the inferior margin of the patient's liver edge. To appreciate that more, you tell the patient to take a deep breath. That brings the liver down, and then exhale. And if you were to feel the liver, you're just trying to appreciate with the tips of your fingers if it's nodular, if it's smooth, non-tender. So do it one more time. And you can feel hers right here, and then exhale. Okay? So the last thing that we'll do, remember I said when I palpated deeply, the area of the bladder is here, and sometimes patients present with chief complaints and with signs and symptoms that may overlie the genitourinary system. So part of the abdominal exam would be to kind of make sure that you're looking at the patient's face and all that when you're palpating the bladder, but also you want to palpate for CVA tenderness, so costal vertebral angle tenderness, especially with a patient that has a complicated, if you suspect a patient with a complicated urinary tract infection. So you have the patient to sit up, and we will push this footrest back. And then just so you guys can appreciate what I'm doing, I'm gonna have Aaron turn around. And then you place your hand on both lateral edges of the costal margins, and you just lightly tap to see if the patient has pain, okay? Lightly tap to see if the patient has pain. You don't want to hit it really hard, because if that patient does have true pyelonephritis, they're gonna feel even that slight tap. So of course a very strong tap will cause them significant discomfort. Okay. All right, so after we have auscultated all the vasculature, we also want to assess, especially in older patients, we want to assess for the size of the aorta. Some patients, as they get older and the vessels walls become a little bit non-compliant, patients may present with an aortic aneurysm, so abnormally enlarged aorta, and we can assess that actually on physical exam. And so we can use the edges of our palms to feel the pulsation of the aorta as we press down very lightly. Of course, if a patient has an aneurysm, you don't want to press down too hard. We want to press down and feel for the pulsations in our hands. And usually that should be less than 3 centimeters. And so I typically start off very close, maybe a centimeter or 2 apart, and feel for the pulsations, and then very slowly inch my hands out just a little bit more laterally to see if I still feel the pulsations, and then again, and I can't feel them now, so I'm going to bring them back into where I was before, and then I see that it was this is kind of the measurement, and I just know that that's probably about 2.5 centimeters, but I'll confirm that. and it is 2.5, almost 3 centimeters, okay? So now we're going to move to some of the special techniques that you can assess a patient with pertaining to the abdomen. Some of these techniques will help us to assess an acute abdomen, so a patient that has suspected appendicitis or suspected cholelithiasis, and also if a patient has a protuberant abdomen that you may suspect related to ascites in a patient that has complicated cirrhosis, then you can also do a special technique as well. And so we'll go over these techniques now. The first thing that we're going to do is some of the special techniques that are related to cirrhosis of the liver. Specifically, we're going to assess for underlying ascites. So when a patient comes in, like we talked about earlier, we looked at the bilateral flanks to see if we had any bulging of the flanks. Sometimes we don't know if that's a protuberant abdomen or if it's a patient that has acidic fluid within the peritoneum. And so there's a special test that we can do on the examination table to confirm that, all right? So typically we ask the patient to help us out with this examination. Sometimes if the patient is unable to assist with this, we can bring in a nurse or someone to help us, and they can place their hands midline on the abdomen to kind of help to kind of decrease the transmission of fluid, or we can have our patient to help us. So Erin is going to help us by placing her hands as such. And then I'm going to take my non-dominant hand and place it on her right flank. And I'm going to use my dominant hand to place it on her left flank. And in this maneuver, we're going to kind of lightly, very lightly jab her left flank to see if we can push or propel the underlying fluid over to the other side. And you should feel if the patient had a severe to moderate, so moderate to severe ascites, then you'll feel kind of a light tap on your non-dominant hand as you are displacing the fluid within the peritoneal cavity, all right? So I'll just jab, and that fluid will hit kind of my hand as I jab. It'll kind of hit my hand. And so you're really assessing, paying more attention to the left hand to see if you feel that tap, all right? If you feel that, then that would be a positive fluid wave. All right? The next thing that you can do to assess for ascites is shift in dullness. So when we percuss the all 4 quadrants of the abdomen, we were listening for areas of tympany predominantly, or sometimes you may have sporadic areas of dullness, but typically around this area, this should be tympanic. So if a patient has ascites, remember those bilateral flank areas will be bulged. And why are they bulged? Because all of the fluid with gravity has dispersed to the flanks. So that fluid is no longer kind of midline, it has now dispersed and shifted to the lateral flanks, okay? So the same with the inferior portion of the abdomen, all of that fluid should have kind of shifted a little bit lower. And so we can kind of use our hands to see if we can appreciate that disbursement of fluid, okay? And so I always kind of start off, I'm on the right side of the bed, so I'm going to start off on the right side, and I'm just listening for tympany to a shift of dullness. So if this was a patient with ascites, let's just pretend like this patient has ascites, I will kind of show you how I would mark that patient's abdomen, okay? So it would be tympany, tympany, and let's just say it turned to dullness because she has ascites. And to say that was dull. And we did the same all the way around, and they would be transitioning from tympany to dullness, okay? So then we would have kind of marked her abdomen up like this, and she would have a shift from tympany to dullness, all right? So then the next thing that we would do, we want to see if we can appreciate a shift in dullness, okay, from a change in position. So I will have her to change to her left lateral decubitus position. And I can stay over here. And now if we just, think about it, if now the patient is on her left side, so all of that fluid should shift to from the left flank. So all the fluid that was in the right flank that was here has now shifted and it's all pooling kind of in the left flank. And so if we think about that, then we should appreciate tympany from here, and then that tympanic area should shift to dullness, okay? So she doesn't have ascites, so we heard tympany all the way through, but let's just pretend that this is where it turned into dullness if she had ascites, and then we would keep doing the same thing and keep doing the same thing, and then have her turn back over, and we see that there is a positive shift in dullness. So what does that tell us? This patient doesn't have an obese abdomen. His abdomen is distended, likely because he has severe to moderate ascites. Okay? So if you have a patient that you suspect has cholelithiasis, you can have the patient to, remember, when we have the patient to take a deep breath, that brings the liver down and closer kind of to the abdominal wall. And you can use that to help to see if the patient has irritation of the gallbladder. And one of the signs that we can test for that is Murphy's sign, okay? And so you can just kind of use your finger, cup underneath the costal angle, and when the patient takes a deep breath, that will bring the liver down and also the tip of the gallbladder. And if the patient stops breathing, so if they have an abrupt cessation of breathing or pain in the area of your thumb, then that is a positive sign, basically, okay? So kind of cup underneath until tell the patient take a deep breath. And that's bringing it down. If this patient had a positive Murphy sign, then they would have an abrupt cessation of breathing on inspiration. Okay, so the last special technique that we're going to talk about, or the last few tests that we're going to talk about, are special techniques to assess for a patient that has appendicitis. So the very first thing, and I like anatomy, location. A lot of these patients are going to present with right lower quadrant tenderness. And so if you kind of divide from the area of the anterior superior iliac spine and the umbilicus, and draw an imaginary kind of diagonal line and split that into thirds, 2/3 down the way is the McBurney's point. All right, and that's kind of the estimated area of where the appendix would lie. All right, and so you can lightly palpate if that patient had pain. You can lightly palpate 2/3 down the way of that imaginary diagonal line, and just kind of deeply, and you don't even have to deeply palpate. They will have pain. If they have pain in that area, then that is positive. Okay. Another thing that you can do is do the psoas sign. So remember, the next two examinations that we're going to talk about, you're really, these patients, basically, when the appendix gets a little bit inflamed, you have an inflamed organ that has basically visceral type of pain. But as that viscera begins to get inflamed, it starts to inflame the overlying peritoneal lining as well. Once that lining gets irritated, any kind of movement, if I were to hit the patient's bed, if I were to palpate the other side of her abdomen, that pain would be referred to this area in the right side. And so some of the examinations that we're going to talk about now is not only related to that kind of peritoneal pain or extension of the pain, but we're also assessing some of the overlying muscles that are close to them. So the psoas muscle and the obturator muscle, if you kind of tense those or move those in any way, then you can, it'll cause or affect the appendix that is overlying that. Okay, so just kind of keep that in mind when we talk about some of the other examinations that we're going to perform. So the psoas sign, you have the patient on the right leg, have the patient to flex against your resistance. And if they have pain in that quadrant, so the right lower quadrant, then that is positive. That's a positive sign. Okay? And then you can do the obturator sign, and we'll keep her covered. But you can flex at the hip and also at the knee, and internally rotate at the hip. Okay? And if the patient has pain in the right lower quadrant, then that is positive. All right, and that is kind of a passive test. You manipulate the patient's lower extremity, and if the patient has, the next exam that we will do is the Robsing's test. And if the patient has pain on deep palpation of the left lower quadrant and abrupt release, if that causes pain on the right side, right lower quadrant, then that's a positive test as well. So this concludes our abdominal examination. I would like to thank Erin for allowing us to do the examination on her. Just keep in mind, as a student, when you're doing your physical examinations, you're not only kind of going through the motions of doing a physical exam, you are also doing it and keeping in mind all of the data that you have collected during your interview, all of the data that you got from the patient's diagnostic tests and things like that, and you're trying to put everything together to come up with a differential diagnosis. And so after you find something, of course, you don't want to kind of jump the gun and tell the patient of all the abnormal things that you saw at the bedside. You want to let them know that you will kind of leave the room and go get the patient's chart and consult with the team and any other consultants that are helping you assess the patient. Okay? All right.